For those of you who don't know me, I am Danielle Hicks. I am Chief Patient Officer here at Go-To Foundation, which is a real fancy way of just saying that I oversee an amazing team of people that help to educate and support our lung cancer community. Tonight, we're going to be talking about resistance to therapy. What does that mean? What you should know about it, how to talk to your healthcare provider when you might be at this crossroads in your treatment journey. And we could not be more thrilled to be having this conversation. I know this has been a huge area of interest, particularly for those folks in our community that interact with Go-To on a regular basis, whether it's through the helpline, through this programming, Gathering Hope, or our online community, where we field a lot of questions from folks around the globe who are currently living with lung cancer. So welcome, welcome. Tonight we have Jyoti Malhotra. I don't know if I said that right. Was it close?
That's great. You're doing great. Go ahead.
She's the Director of Thoracic Medical Oncology and Associate Professor at the Department of Medical Oncology and Therapeutics Research at City of Hope. So she is our neighbor right down south. I know some of her colleagues, and I hold them very near and dear to my heart. This is her first time here at the living room, so we were thrilled to have her come and speak to you all tonight. The objectives tonight, as I said, is for folks to understand what resistance is, what it means when you hear the word resistance or your cancer has become resistant to therapy, to understand the steps to take and questions to ask when your cancer has become resistant, and to really understand the importance of clinical trials. You guys all know that are veterans here know the sweet spot I have for the clinical trial space and how important it is for a multitude of reasons, and we're going to jump into that tonight. So I think we should start with something pretty basic. What does resistance mean?
Right. So when a patient is on cancer treatment, many times it's working, and it works for a certain period of time. But for advanced lung cancer, we know that it doesn't work forever. At some point, the tumor cells or the cancer cells will understand, and they will learn a way to stop responding to that cancer treatment. And that's because the cancer cells do not stay the same, right? They divide and they multiply, and during this process they evolve. And they evolve and they try to learn ways how to become resistant. And it could be so many different ways. The cancer cells can acquire a different mutation, a second mutation, or a change in the DNA. The cancer cells can find a way to stop being recognized by the immune cells, or the cancer cells can just learn how to get the chemotherapy out of the cells and not letting it stay inside the cancer cell. So there's so many different ways in which resistance happens. There's really no way to predict how long or what would be the mechanism. It could happen in different ways. It can happen in different patterns. It can happen at one site, or it can happen at multiple tumor sites. So it's very heterogeneous, and something that we are trying to understand as we do more research in this area.
So I think it's really important that you said there's no way of knowing, right? No one cancer is alike, and I think this is where people kind of get tripped up,
right?
Especially if they're consulting Dr. Google about their therapy and looking at how long that therapy might last based on studies. But I think it's important to point out that, again, not everyone's the same, and the numbers you're given are median. We aren't talking about people that fall on either side of median, and nobody knows who or where.
Exactly. There is no really way to predict, but there are some factors which we study and we try to look at, which may kind of give us a prognosis, right? Like, so if a patient has involvement of only one organ compared to cancer which has spread to multiple areas, or if they have certain features, certain mutations which predict a shorter response to treatment. So there are a lot of different factors we can sometimes use, and we are trying to build these models, and I'm hoping in the next 5-10 years we can have very accurate models in which we can predict the time that the treatment would respond, so that we can proactively do more to prevent the emergence of resistance. And there are new techniques we can use, but that's still something that we are still learning more about. And for now, the best way to find resistance early on is to keep on doing scans regularly while someone is on treatment, so that we can identify development of resistance when it's really at a very early stage and when it hasn't really caused the cancer cells to multiply and divide very rapidly and grown big. So the best way is to catch it early so we can intervene and try to treat it early rather than waiting till it has progressed to a time where it is more widespread.
Yeah. So before we jump into, from like a clinical perspective, what steps you take to monitor this, is there a way for patients, or do they ever know when something might be happening or something might be changing? Are there things that patients should look out for to have conversations with their healthcare providers about?
So one way would be if someone started getting symptoms from the tumor starting to grow again, right? And it could be a lot of different things. It could be more pain, or it could be more difficulty breathing, or more cough. So if symptoms change at any point, or if someone is having a feeling that something is not the same and they're spending more and more time in bed, or they're doing less and less physical activity that they were doing, that is probably the time to bring it to the attention of their care team or their physicians. But other than that, sometimes we don't identify resistance till we actually find it in the scans.
So I think it's important, because I know in speaking with people who have been diagnosed with lung cancer over the last 15, 16, 17 years, quite often, even when patients become symptomatic, they're hesitant to reach out to their doctors because they're afraid that means coming off of treatment and not understanding what a next option might be. But what I hear you saying is, no, it's important if something changes to have those conversations.
Absolutely. It's better to ask questions and try to bring something to your physician's attention rather than just keep on thinking if this is significant or not, because we don't want to delay any step that might be there in the workup or in the treatment. And an important factor to consider here is that a lot of patients with lung cancer have symptoms such as fatigue, shortness of breath. These are very non-specific symptoms, right? So it's hard access to know if the symptoms are getting worse. How do you measure fatigue, for example? And on top of that, if a patient is being hesitant, that only makes it worse. So I think the best thing is just bring it to the attention of your physician, just ask questions, just tell them. Believe me, we never feel like we are being bothered. We really want to know early, because we as physicians can help our patients if we know of something earlier rather than at a later time. We have more options if the disease is limited rather than at a later time when it is more widespread.
Yeah, and just as a sidebar or a side note, and my personal opinion is, if you don't feel like you can have those conversations with your healthcare provider, then call me, because we'll find you one that you can have those conversations with. And just a quick question while we're on this patient sort of experience part of it, because I think it's so important for the community to hear from other people who have walked the walk. And no pressure to the folks in the room who I know have experienced resistance, but does anybody want to grab a mic and talk about whether or not you had any inclination that maybe something was going on? Thank you, Larry.
Multiple times over the last couple of years, I had localized progression, primarily in lymph nodes. None of those times did I have any indication that there was anything going on. One rule of thumb that my oncologist told me very, very early in my lung cancer life, when you have lung cancer, you're hypervigilant. If your fingernail starts hurting, you're aware of it. So what she said to me was, if something happens and it lasts for a couple of days, that's just what happens. But if it goes for a week or 10 days or 2 weeks, tell somebody about it.
Thanks, Larry. And I know, Rick, you sort of have a motto about, well, I'm not going to speak for you, sorry.
So I was diagnosed 9 years ago. I'm a 9-year survivor. I've had progression several times, and there's always been another drug available. So my biggest thing is, all you have to do is live long enough to get to the next best thing. And I've done that since the beginning. I started with crizotinib, and when I was first diagnosed, crizotinib was the only game in town. I'm ALK positive. That was the only game in town other than radiation and chemo. So then there was trial medicine, then approved medicine, another approved medicine. I mean, I've had 6 different protocols on different drugs, and now I'm on a NVL 655 trial. So I've always wanted to live on the edge of whatever the best thing is, because I want the best for me. But also I do the trials because I want to be able to provide that science for the rest of the world. If nobody ever did it before, I wouldn't be sitting here today.
Yeah, thank you guys for sharing your stories, because I think it's really important and relevant, particularly, well, in general, but particularly to the conversation we're having tonight. So I want to jump to the healthcare provider sort of space in this. And you mentioned that they're scans, right? And we do these scans because we're trying to monitor how well not only the drug is working, but if and when it might stop working. Can you talk a little bit about what those scans are? And there's either CT with contrast, or PET, when those are appropriate. There's a lot of sort of discrepancy or differences, I guess, around when and how often someone might be being scanned. So
Yes, so that's really a great question, because it's so relevant and so important to informing us about what's going on. So the 2 scans which are most commonly used are CAT scans and PET scans, and those are for the body. For the brain, it's always the MRI, which is the best test unless someone can't really have it. So for brain, it's MRI brain. For the body, it's either the CAT scan or the PET scan. Now, CAT scan is really the gold standard because it has a lower chance of having false positives. In PET scans, as many of you probably know because you have already had it, it basically, things light up. And sometimes things which are not even cancer can light up, causing a lot of anxiety and causing a lot of red flags. And therefore, most physicians prefer to do CAT scans to monitor and use PET scans in situations such as at initial diagnosis or at the time of progression, or if the CAT scans are not clear. In terms of timing, it's usually every 2 to 3 months, unless there is a reason, such as patients are having some symptom which needs to be evaluated earlier, or the last scan showed something which was not very clear, and the doctor may decide to do a scan sooner for follow-up. For some patients like you, Tina, who's been on a drug for 12 years, we can actually space it out then once we know that the disease is in good control, and we don't want to put our patients through a scan every 2 to 3 months, and then we slowly space them out to like 4 months or so. So it really needs to be tailored to the patient with certain guidelines which we use in common for most patients.
And I know there are studies out there, and I know, Joanne, you were involved in one, and others who participate in this, to use blood to sort of monitor whether or not, and I know nothing's technically been approved yet, but what are your thoughts sort of on that and where that might be going and how that might impact how we're looking at cancer treatment moving forward?
Right. So blood is a useful tool for liquid biopsy, and that's the term we usually use. Some people use circulating tumor DNA, cell-free DNA, and what it really means is that we take blood from the patients and we try to isolate tumor cells from the blood sample and sequence those, as well as monitor or measure those. So there are 2 things we can do with that. One, we can see if with treatment the number of tumor cells have gone down in the blood or become not measurable at all. And the second thing is to actually sequence those tumor cells and see if there is any evolution of the mutations in the tumor. Now, there are certain limitations. If someone has early stage lung cancer, or someone has very, very small, low level tumor left in their body, they're not going to be shedding tumor cells in the blood, and we might not find an answer. And there are certain things we still cannot do. We cannot check for PD-L1 expression. We cannot check for certain other markers, especially the protein-based markers in the blood yet. But we are trying to see how we can leverage whatever information we can get to inform us. And that, as you mentioned, it's something we are still learning. But in the future, I do see it as a great tool in which we can, rather than wait for 2 or 3 months for the CAT scans or the PET scan, we can try to understand and measure if the patient's progress is going in the right direction or the wrong direction, and if something needs to be done in terms of escalation of therapy or changing of therapy early on based on that.
So I think this is a good time to sort of jump into care standards. And they vary based on what type of therapy a person diagnosed might be on, whether it's chemoradiation, targeted therapy, immunotherapy, or even, as you and I talked earlier, ADCs. So let's talk a little bit about what that looks like in these different areas, maybe starting with chemoradiation. What happens then?
Right, so chemoradiation is really used for stage 3. That's where we use it primarily. The goal is cure. Occasionally, we may use it in patients even with advanced or stage 4 lung cancer if their disease is localized, even though it's technically stage 4, and we can use it to get good local control. But it's very different from, say, systemic treatments like targeted treatments or immunotherapy, where we are giving the drug either through the vein or through orally to try to get to every different area where the tumor is, not necessarily just to the lung. While radiation is very localized, it can only treat one site, which is most often the lung.
So let's jump into targeted therapies, because I think this is where it gets a little more complicated and a little more nuanced, where folks really need to understand what next steps are, particularly when we're talking about, well, next steps. I'm going to let you tell the story.
Oh. So targeted therapy, this is 2024, so it's actually been 20 years since erlotinib was used for EGFR mutated lung cancer. So it's a big year for us, right? Two decades. But basically the first step is to try to learn what's driving the cancer. Learn what driver mutation or change in DNA is driving the lung cancer for that patient. So now we're really talking about precision medicine, right? It's no longer one treatment fits all, like you just mentioned a few minutes ago, that 20 years ago, we had 3 or 4 chemotherapy drugs and every patient with lung cancer got those drugs and that was it. But these days, it's really precision medicine driven. Both at diagnosis, where based on the mutation, whether it's a EGFR or ALK or ROS1 or whatever the mutation is, the treatment is really tailored to what's happening in the patient's tumor. And the same story applies at progression also. When there is emergence of resistance or the patient's tumor is progressing, we really have to learn what's driving that. And that's important because, as many of you know here, that helps us picking the right second or the right third therapy and guiding you so that you can live long enough for the next best things comes around. So it's really very important to get information about exactly what's happening, what mutation is driving it now. And the other thing that Larry, you mentioned was localized progression, and that's something I think we can talk about for a couple of minutes, because if a patient has, say, lung cancer which is stage 4, and there is involvement of many areas, right? It's one organ site, 2 organ sites. The evolution or the way in which the cancer cells are evolving at each of these sites may be different. And that's what we call branched evolution, meaning at all those sites, the cancer cells are not going to mutate and evolve the same way. And that's also another important thing. While we need to catch the resistance early, while it's only localized to one spot or 2 spots, because that's where the role of radiation comes in. If it's only becoming resistant at one site, we can just radiate that one site, hoping that we have killed all the resistant clones or resistant cells there, and then continue the same treatment. Because eventually our goal is to get as much time out of each treatment as possible, so that it becomes more of like a chronic disease, right? You just keep on changing the medicine every few years.
So for those of you who are not new to the living room, you've heard us talk in this meeting before about oligometastatic disease or oligo progression, and that's kind of what we're talking about. And if we know, just to kind of recap, if we know that systemically the drug is working, and I'm making this number up, but in 90% of your tumor sites, but there's that 10%, maybe it's one tumor, maybe it's a couple little spots that have just decided to kind of go rogue then you can, and I'm using lay terms because I think it's easier for the people to understand, but then you can kind of spot treat them and then keep an eye on everything else to make sure that those are all still staying stable and responding to the current treatment without changing the systemic treatment. But I want to go back to something you were saying about rebiopsying at the time of resistance or progression. It's so incredibly important, and Dr. Gandera, who is a medical oncologist up at UC Davis, he's been doing these living rooms since we started those living rooms, and he always talks about the bus, and if the tumor was the bus, you always need to know who's driving the bus. And this is in the targeted therapy realm. Who was driving the bus? And whoever started driving the bus might have taken a break, and somebody else got on to start driving the bus now. So it's so incredibly important that you know always in this targeted therapy space who your bus driver is. I see you with your mic, Rick.
So in my journey, I've had really persistent brain metastases. I went from 3 back in 2016, now I have like 30. But they're all, sub-centimeter. Most of them are sub half a centimeter. They're small. And life just goes on. But along that journey, I've had CyberKnife. When you get one that's, say, a 2 or a 3, and then it's a 5, and it's an 8, and whatever, in successive scans, then we would just do CyberKnife, and essentially they call it weeding the garden. So I've been weeding the garden, for years now. I've had CyberKnife done on 3 different occasions on 7 different sites, and never the same site twice, so it does tend to knock out what's there. But basically, other than that, we just do the regular treatment, changing, to another one just because it might work better, but not really because we had massive progression. Does that make sense?
It does, and thank you for bringing up brain metastasis, because that's such a relevant topic, because now that patients with lung cancer are living longer and longer, and we are seeing more and more patients being diagnosed with brain metastasis, because the brain is different from rest of the body. There is a blood-brain barrier which exists between the brain and the rest of your body, which means drugs have to be very small in order to pass that, right? So chemotherapy cannot pass through it. Immunotherapy, who knows? We are still learning. But targeted therapy, especially the ones you've been on, like the ALK inhibitors, really penetrated well. But there are certain caveats to it, right? Because the blood supply is different or whatnot. If a tumor is a certain size, probably the drug may not be getting into it, and that's why you require the gamma knife now and then. But for the most part, the ALK inhibitors do a good job of controlling the disease in the brain as well. But it's not the same for all targeted treatments. EGFR inhibitors are good, ALK inhibitors are good, but some of the other inhibitors, like say the MET inhibitors, the BRAF inhibitors, we are still learning more about them. So again, coming back to the point that every patient's treatment plan has to be really tailored to what their mutation is, what we are using to treat that mutation, what's the CNS or the brain penetration of the drug they are on. And sometimes we don't have the answers, right? Because a lot of these mutations are not that common, and it takes us a long time to collect data and do research and have enough information to make a determination. And in those cases, we do the best we can, and that's how we learn too, by treating patients and learning from their experience as well.
I always say that's why they call it practicing medicine.
I think talking about brain metastases is very, very important. The lung cancer in particular likes the brain.
Yeah.
Different cancers like to spread to different places, and the brain is one place. And I think Rick's point, well, first of all, stepping back, the blood-brain barrier, you think chemotherapy, it's a liquid, how does it not pass? And it really, listen, I'm not a chemist, I'm not a scientist, I don't know, but it's about how big the molecules are within that drug and whether or not the molecules can pass the brain. And to Jyoti's point, it's chemotherapy molecules are too big. But with that being said, and going back to an earlier point, because you know how I'm always trying to sort of connect the dots during these conversations, when we're talking about clinical trials and studies, when gamma or CyberKnife to spot treat the brain first came out, and correct me if I'm wrong because it's been a minute, but it was approved on like 4 to 7 lesions, right? And that was it. So if you had any more than 4 to 7 little spots on your brain, people were like, we can't, that's all we can do. And
So
now,
that's a great observation, and
Yeah.
you're right. And it's really hard to do these trials, right? How do you do these trials? Like, what number do you start with? Do you do a trial with like 5 spots, or do you do a trial with 10?
Yeah.
And how do you find the difference between 5 and 10? So it's difficult to do these studies, but there are centers now who are treating up to 15, up to 20 different sites as well, just because they know that it's very targeted, and if they know that the backbone is some kind of systemic treatment, which will provide at least some control to the tumor. So that number, you're right, has been increasing slowly. The number of brain spots that can be treated with radiation or gamma knife or cyber knife or whatever you want to call it, basically targeted radiation.
and anybody who wants more information on radiation, please check our video library where we'll go into way more detail about what we're talking about with cyberknife and gamma knife and targeted radiation therapy. And I say that mostly as a reminder because a lot of people are afraid of radiation and what that might mean, but the limited and the small 4 millimeter lesions that they're able to target and eradicate is really, really technologies come
Exactly.
a
It's
long
very
way.
focused, no scatter in the surrounding areas for the most part.
Yeah.
Very different from the radiation like 20 years or 30 years ago.
Yeah, for sure. I do want to jump to immunotherapy.
Okay. So that's a harder one for what to do for resistance, right? Because targeted therapy, we have been very fortunate because we have been able to identify more mechanisms of resistance. For immunotherapy, we are still learning. And we have learned certain mutations which predict either initial resistance to immunotherapy. So even when the patient is newly diagnosed, immunotherapy works for some patients, but not all patients, which means some patients, those patients who are not responding even at new diagnosis, have what we call primary or initial resistance to immunotherapy. A lot of targeted lung cancer or lung cancer with targets like EGFR and ALK have that primary resistance. They don't respond to immunotherapy. And then there is something called acquired resistance, in which when we treat patients with immunotherapy, the tumors will respond for a certain period of time. And then at some point, the cancer will stop responding. We have identified certain mutations as well as non-genetic mechanisms of resistance. We still do not know what to do about them once we identify them. So we do not have as clear of a path for immunotherapy resistance as we have for some mutation-driven lung cancers such as EGFR and ALK, and that's something that we are still trying to understand more. And when resistance to immunotherapy happens, and if the tumor does not have any mutations that can be targeted, our approach is usually to try a different kind of chemotherapy, try a different trial, a clinical trial, or try one of the new upcoming treatments, which we can talk more about, such as antibody drug conjugates, to name one.
Yeah, we might as well jump into the ADCs.
Okay.
Yeah, let's do it.
So in addition to targeted therapy, so usually when we think of targeted therapy, what comes in our mind is a pill that we take every day, which falls into the class tyrosine kinase inhibitor, meaning it's blocking where the mutation is, the receptor there. But now there are upcoming new treatments. So antibody drug conjugate is one, which is in a way targeted therapy as well, but it's different from the targeted therapies we have been using in the past, in the sense that in antibody drug conjugate, each drug has 2 parts. One part is the chemotherapy part, and the second part is actually an antibody which goes and binds to this protein which is expressed on the tumor cells, which means that when we give that drug to a patient, because of that antibody part, the drug goes to where the cancer cells are and binds there, and because of the chemotherapy part, that chemotherapy then acts. So it's in a way targeted chemotherapy. So it's more specific, but at the same time, end of the day, it is chemotherapy. So we see some of the side effects we usually see with chemotherapy. And there are a number of different proteins that can be present on lung cancer cells which have been identified, for which we are developing these antibody drug conjugates or ADCs, such as TROP2, DLL3, and so forth.
So, and I just want to touch on this for a minute. Again, we've had past and will have future conversations in this format around it, but the supportive care that goes, I don't want people to be afraid of chemotherapy, because there's been all this discovery and a lot of conversation in the community, particularly around targeted therapies and immunotherapies. And if someone isn't on one of those and they get to a chemotherapy, there's this sort of sense of feeling defeated, right? At least from my experience. And so what I want to make sure people understand is today's chemotherapy is not your grandfather or your great-grandfather's chemotherapy. And what we call palliative or supportive care that is there to help counteract any potential side effects and improve quality of life. I think it's really important to point it out. People tend to be disappointed and I don't want to say more afraid, but again, from my perspective, it feels a little more daunting for folks who have to go on chemo.
And part of it is because historically chemotherapy has always been associated with feeling sick and side effects and not getting out of bed and so forth. And over the last 20 years or so, we have made all this progress, but our perception of chemotherapy is still the same. But it has really evolved. The drugs we are using, for example, for lung cancer, we are using drugs like pemetrexed, for example, which is chemotherapy, but it wasn't around 20 years ago, and is much better tolerated than some of the other chemotherapy drugs. And this is just an example. And secondly, to what you pointed out, we have better drugs to prevent side effects as well as manage side effects if they do happen. So the experience with chemotherapy now is much different than what it was a few decades ago. So I think we have to now think of chemotherapy as a partner to the other good therapies that are out there, like targeted therapies and radiations and immunotherapy. But chemotherapy is a good partner because there's synergy when you sometimes use chemotherapy with some of these other drugs.
Yeah, especially when you're looking at it in that capacity where it's a targeted chemotherapy. Larry?
The proteins that are present on the surface of the tumor, how do you know if you have DLL3? What's the determining factor to find that?
So more testing, but the test is different, right? So for molecular testing, we take out DNA or RNA from the tumor cells and we do sequencing. For the protein, the test is different. It's something called immunohistochemistry, and it's using special stains. They stain the tumor slides and then they look at it under the microscope, and now there are machines to do it. Basically, it's a different assay than what we have been using. So if someone had molecular testing, we would not have information about the expression of those proteins on the cancer cells. That will have to be a different test.
So I do want to address the small cell question, similar to where non-small cell, particularly adenocarcinoma, was 20 years ago, and all of the great advancements that have been made in the last 2 decades. Small cell is starting on this trajectory, and it's so exciting for me to see happen, and obviously for the folks diagnosed. But some exciting things have happened, and there's some exciting things on the horizon, particularly in the third line place, which there never was third line sort of place before. Can you talk a little bit about that?
So we don't want to take too much time, but 2 things that I really want to talk about. So one thing is, when you look at non-small cell lung cancer, it's no longer one disease. It comprises of many subgroups, right? And that's why we've made all the progress, because we are approaching each different subgroup in a different way and not really treating everyone in the same way. But that's not something we have been able to achieve for small cell lung cancer for the longest time. We just treated everyone with small cell lung cancer in the same way. But more recently, we have finally been able to divide small cell lung cancer into subgroups too. And now trials are ongoing in which we are trying to tailor treatments to that subgroup. And the subgroups are really determined by the expression of certain transcription factors or certain markers which are there on the cancer cells. But we are getting to a point where, like non-small cell lung cancer in the future, small cell lung cancer will also be categorized, and the treatment will be more tailored to the patient's individual tumor rather than everyone fits all kind of approach. So that's, I think, one great advancement we have made for small cell lung cancer. And the second is that we have found some new drugs. So another class of drugs we haven't discussed is bispecifics, and Danielle is nodding, but bispecifics are different from antibody drug conjugates, but kind of the same concept in the way that we are just combining different things together. So there is the chemo part, and then there is the part that binds to the cell or the tumor cell, and then there is the part that engages the immune cells or the T cells and make them start recognizing the tumor cells and killing it. So similar approach in which it's given IV and then it goes to the tumor cells. So for example, DLL3 is one target used for small cell lung cancer, but then not just the chemo part, it also has the T cell engager part, meaning it has the part that engages the immune cells and makes them kill the cancer cells. So there is a drug on the horizon, and there are a lot of other drugs that are being investigated. Tarlatamab is one of them, and it's already passed through some of the trials. So we look forward to getting more approvals and more access to drugs in that space.
Absolutely. Can lung cancer become resistant more than one time to a therapy?
So yes, we have examples here. So yes, it can, because that's why stage 4 lung cancer cannot be cured, because regardless of which treatment we use, at some point of time, it will become resistant to treatment, and it can happen over and over again. And there's usually a different mechanism of resistance every single time that comes into action.
It's knowing and understanding that mechanism, and thinking back to what we talked about a little bit ago, just about resistance in general, still applies if you resist again. So
again, testing and trying to understand the mechanism of resistance, trying to find a treatment that is tailored to that.
Who's driving the bus now? But there are currently a lot of trials looking at drug resistance. And I know, particularly in the targeted therapy sort of realm, EGFR being the most sort of prominent, and there's been the most things happening. Folks having been on Tagrisso now for a while, all the folks that I work with and that we talk with all the time about, you need your plan A, B, C, D, E, like keep going down the line. To Rick's point, keep watching what's coming down the pike. Are there a lot of studies right now looking at varying types of resistance? And what should and or do folks need to know about it, and should they be having conversations with their healthcare providers?
So all great questions. So yes, there are a lot of trials ongoing looking at resistance. But when you try to narrow it down, so say for lung cancer, there's probably in the thousands, and when you try to look at EGFR mutated, it comes down to hundreds, and if you look at third line or fourth line EGFR, it's probably in the tens. So there is a lot of trials, but because we have different subgroups, they are probably limited for each subgroup. So it's important to understand that, and also to have a plan B for the day when the resistance happens, because there is a small window where the patient needs to find a new treatment. And if that happens, the first thing is to talk to your oncologist and see if they have any trials at the cancer center where you are being treated, and then look for trials locally, and sometimes your oncologist can connect you. The other option is to work with patient support groups, because they usually can sometimes connect with the appropriate trial, online clinicaltrials.gov. So there are resources available, but at the same time, all this needs to happen within a few weeks if progression or resistance happen. And in terms of when to have a conversation with your physician, it's not something that you have to talk about at every visit, but you definitely should have a conversation so that there is a clear plan of action when the day comes. Like, you should know if your cancer center has phase 3 trials or also has phase 1 trials, if there is something coming up in the horizon. And also sometimes there are trials which are meant not for patients who have resistance. They're actually for trials for patients who are already responding pretty well to get even deeper or bigger responses. So it's always good to have a question, to have the question and the discussion with your oncologist, have a plan, know what are the resources ahead of time.
Yeah, and this is always the point of the conversation. Well, I will always and forever do a shameless plug for Lung Match at GoTo, and those are our clinical trial navigators, and they are fantastic and will help you not only to understand where you might be and which clinical trials you might qualify for, because we all know clinicaltrial.gov is impossible for the layperson and a lot of healthcare providers to navigate. So we can really help you navigate that process and then help you with questions to go back and ask your healthcare providers. As Jyoti just said, and has said multiple times throughout this, and I think it's really relevant, particularly in the non-small cell lung cancer space. Lung cancer is not one disease, but non-small cell lung cancer has really been broken down into a series of rare diseases, if we really are sort of breaking it down. And there are experts out there in the lung cancer space who are choosing to focus in some of these smaller, more rare areas of disease. And we can obviously help you with those second opinions too. And these docs, I'm telling you, that we work with around the country and around the world are more than willing. And I say this, not necessarily to the people in the room, but also for the people in the room, but particularly the people that live in the rural areas of this country who don't necessarily have access to these experts. We can help support with access, and these physicians are willing to work with your local healthcare team to help get you the care you need or that is right for you at that time in your community. So please don't hesitate to reach out to the PSS team at GoTo to help support that for anybody who might be in need. I want to thank Dr. Malhotra for coming and speaking with us tonight. I really hope you'll come back. It's been an absolute pleasure having you here and having this conversation. And then of course I need to thank our supporters. Without their kind support, we would not be able to bring you this programming or like programming and education. So Amgen, AstraZeneca, Bayer, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Merck, Mirati, Novartis, Novocure, Regeneron, Sanofi, and Takeda. Thank you so much for making this possible each and every month. And have a great night, everyone. We'll see you in February.
So I'll be brave if you're brave. I'll be brave, but only if